Come inside the cath lab to see a heart valve replacement and learn why the patient chose to have this done and why doctors say this procedure is the key to protecting his heart. Good morning, I'm Alexis Del Cid. Welcome back to All Things Heart. Keith Holmes Jr. was born with a congenital heart defect called tetralogy of Fallot. That's a combination of 4 heart defects, and we were there as he underwent his latest procedure, a heart valve replacement. Wearing his blue surgical cap and hospital gown, 29-year-old Keith Holmes gives our camera a wave as his care team goes over the basics.
All right, can you tell me your name and your date of birth one more time?
Next, they inflate the mattress underneath him. It's so they can smoothly slide Keith from his hospital bed onto the procedure table. Within seconds, he's sedated and asleep. After some prepping, it's time for his interventional cardiologist, Dr. J.D. Surface, and cardiothoracic surgeon, Dr. Trip Zorn, to step in. They'll be replacing an artificial heart valve that Keith got back in 2014. It was when he was 18 years old and still a patient at Children's Mercy Hospital. He's now in the care of the Adult Congenital Heart Disease Clinic at the University of Kansas Health System. The procedure today is called a transcatheter pulmonary valve replacement.
I just wanted to jump on top of things and get it done.
Keith's heart problems have existed his entire life. He was born with 4 heart defects that together are called tetralogy of Fallot. You may even hear people call it blue baby syndrome because the low blood oxygen levels can cause baby's skin to look blue. Today there will be no cutting through his chest. Watch as the doctors work side by side with the rest of their team, inserting a small tube called a catheter into Keith's groin. Next, they guide the catheter through his femoral vein all the way up to his heart. This tube provides a clear path for the doctors to implant the new valve you see here. They'll use small tools and a wire to help.
Yeah, that looks great.
Dr. Surface and Dr. Zorn can see their work inside him using the large monitors above the table.
I'll have control of your valve, you'll have the wire.
Despite having numerous procedures and surgeries over the course of his life, each one turning out fine, before this one, Keith confided that if he's being honest, he's still nervous.
Every time I'm always nervous. I've always been nervous.
And who wouldn't be? But he knows these procedures are part of living with a congenital heart defect and are what make it possible for him to get back to living his happy, healthy life. We are so happy to have Keith with us now on the set, along with his interventional cardiologist. We have Dr. J.D. Surface, and we have cardiothoracic surgeon, Dr. Trip Zorn. Thanks for making time to join us, doctors.
Good morning.
And thank you, Keith, for coming in today. How are you feeling today?
Pretty good, pretty good.
You look good.
Thank you.
You just had a birthday?
Yes, last month.
Are you someone who doesn't like to tell their age?
I just turned 30 on the 21st.
Yay, a milestone, right?
Happy birthday.
Thank you.
We're so glad you're here. Before the procedure, you said, Keith, that you were nervous. Now that you're on the other side, what are your thoughts?
It was a pretty easy transition. It was pretty easy recovery time, pretty easy surgery. It was pretty good.
That's what doctors like to hear. That's what we like to hear. When it comes to tetralogy of Fallot, Dr. Surface, that's a big name. A lot of people say, what? Can you explain the defects involved, the 4 defects in tetralogy of Fallot, and why it's also called blue baby syndrome?
Sure. Yeah. So congenital heart disease is full of historical doctors who named things after themselves. And so that's what tetralogy of Fallot is. This guy Fallot, hundreds of years ago, noted a couple of patterns that he saw. There were 4 things that he saw in certain hearts, and they were a ventricular septal defect, which is a hole between the 2 bottom chambers of the heart. And you can see that in this diagram up on the screen there. There's also narrowing underneath the pulmonary valve, and so blood has a hard time getting out to the lungs. They had what they called an overriding aorta, which just means that the aorta, which is the big candy cane shaped blood vessel that comes off the top of the heart, it's sitting kind of straddling both the left and the right sides, which you can see there. And then the right side of the heart gets thick. We call it hypertrophied. And that's all just because it's the narrowing outside of the right side of the heart makes it have to work harder, and like any muscle, if it works harder, it gets bigger. The reason it's called blue baby syndrome is because the blood on the right side of the heart has less oxygen than the left side of the heart, and it looks bluer than the bright red blood that you see on the left side. And because of that hole, and because of that narrowing, when the right heart squeezes, and it has a real hard time getting out the right side, it realizes, hey, I could just go through this hole over to the left side, and now you've got blue blood on the left side of the heart, and that's getting pumped to the body, and so babies look a little bluer.
So jarring and alarming for a parent to see that. Keith, I remember you brought your cousin to the procedure, didn't you? Or you brought a family member?
It was a lot of people there, yes.
Okay. One of them had talked to us off camera saying that your mom had noticed you were starting to turn blue, and that's how it was diagnosed?
Yeah, at the age of 2.
At the age of 2?
Yes.
So we're going to dive into how it's diagnosed and different advancements we've made later on in the program. Dr. Surface, you were concerned that Keith's valve was leaking. How could you tell that was happening?
Sure. Well, so Keith had actually already had a pulmonary valve replacement in 2014, as I think you mentioned, but that was done surgically. And so he had a surgically placed valve that was about 10 or 11 years old, and Keith was in regular routine care with us in the adult congenital program, and that involves us getting what we call an echo, which is an ultrasound of the heart, pretty much on a yearly basis, just to make sure that everything looks good. And we had been following it over the years until actually the first time I met you was when we said, hey, this is starting to get a little bit too narrowed and too leaky. And I think there were some sort of subtle symptoms, maybe slowing down just a little bit, but also more than even your symptoms, I was seeing signs on the echo that that right side of the heart was struggling a little bit.
Okay.
And you don't want to let that stay that way for too long.
Right.
And Dr. Zorn, we're going to bring you in 1 second.
Sure.
But I do want to ask Keith, what's it like as a patient to come in here after the surgery and then see it, the procedure, and see it on TV?
It was graphic.
I
never seen it. You know, I'm asleep, so I didn't see them working or talking or anything like that. So it was a little graphic.
Is this the first time you've been able to see images of different things that have been performed on you?
Yes.
The dynamic duo there, working side by side. What's the last thing you remember?
Them counting down for me to go to sleep.
That's good. And then you opened your eyes and...
I was in the room. They was waking me up, telling me, hey, we're going to send you up to our waiting room.
Dr. Zorn,
Sure.
I want to talk to you as a cardiothoracic surgeon. It was fascinating to be able to see this procedure in the cath lab from inside the procedure room. As a cardiothoracic surgeon, how would doctors have needed to do a transcatheter valve replacement 30 years ago?
Yeah, so we didn't have the technology, because the technology we used to replace his valve was based on a device that basically made its appearance about 2009 or 2010 in the US, and it has evolved, and the device we used is about the 6th generation of that device. So 30 years ago, we wouldn't have anything to be able to do this in a catheter-based way. It would have to be open through the chest like he had when he was a kid.
Open heart surgery.
Open heart surgery, yeah.
And technically was what you both did a procedure, not a surgery, correct? Or is it called a surgery?
So it technically is still an operation or a surgery. So it's a little bit, those terms are not, they're a little loose. So,
Okay.
Yeah.
Some gray areas.
Yeah.
Which is great. It's amazing that you can do such work on a heart and actually it be kind of vague. Is it a surgery or a procedure?
Yep.
You're in and out. What tools are you using when you're weaving the catheter up through the leg to the heart?
So it's kind of a simple, it's relatively simple. It's a rail, it's a wire that we position beforehand that guides the device. And so the technology that is innovative is the ability to get the valve down to a small caliber so that it can pass through the vessels, and then get it in position and then open it to its full size without remotely from being able, while we're standing at the patient's hip.
Keith, were you sore afterwards? Was your groin sore?
Yes.
There's been a lot going on, right?
I wasn't in too much pain, but I was pretty sore.
Right. Now, when we see the doctors working side by side, how do you decide who's doing what? Do you plan it out ahead of time? Because we have 2 accomplished, brilliant doctors side by side, who's doing what part of the procedure? Dr. Zorin, I'll start with you.
Well, honestly, we can flip and we can do both parts of the procedure. So in general, we, for all of our structural procedures like this, we have what we call position 1 and position 2. That we don't have to go deep into that, but basically one person is managing the catheter and the device where it is, and the other person is deploying the balloon and using the inflator to inflate the balloon that opens the valve up to where it is. So it's kind of a two-person job.
And Dr. Surface, which one are you in that?
Let's see. I guess I must have been position 1 in this case.
Yeah.
So
Don't say you're the one with the glasses.
Yeah, we're hard to tell apart.
It's because I'm so tall. So I'm the one on the left side of the screen.
Well, now
actually, not there. Yeah. Now we're flipped. So we flip flop, and sometimes we'll decide who's going to do what.
And why did the valves have to be replaced every 10 years? Is it always a hard 10 years?
No, it's not a hard 10 years. That's sort of an average. So these valves are made out of tissue from the lining of the heart of, in this case, a cow. And it's been treated in the best available technology to make it as durable as we possibly can. But the honest truth is your body recognizes anything that's not its own. And eventually, through wear and tear, it will degrade. And it can get thickened and start to not open well or not close well. And eventually that causes problems. We say 10 years, 10 to 15 years sometimes, depending on the valve and the situation, but that's really just an average. And so that's why we need to watch it every single year to make sure, because for some patients it's going to fail early, and for some patients it's going to last much longer than that, and everywhere in between.
Is it always a cow?
No, there's also pig valve variations.
Okay.
There's a whole host of different options.
Is it ever an artificial material? Or is it usually an animal?
Not with the transcatheter valves.
Got it. Okay.
In surgical
interesting.
valves,
Yeah, we have surgical valves that are made of a carbon polymer that are more durable, but those are a fixed size. You can't compress those down to a small size to deliver through a catheter.
Right. That's amazing. Did you have any symptoms, Keith, where you knew, oh, my valve is something's going wonky here?
No, I didn't. It was always the doctors kind of saying that they hear or they seen something on my echo, kind of letting me know.
Well, thank God that you were continuing to go for your checkups and everything.
Right.
Do you remember when you last had this done? It was 10 years before you were a senior in high school.
11 years ago.
11 years ago.
Yep.
Do you remember comparing recovery times, how the first one was compared to this one?
Yes, I do. For the one I got in 2014, the open heart surgery, the recovery time was a minimum of 3 to 6 months.
So it was open heart?
Yes.
The last time you had this done?
Yes, it was open heart. And the recovery time was 3 to 6 months, and I couldn't even laugh without a pillow across my chest, because since my chest been cracked open, anything, any pressure could crack it or crack any bone in my chest. So it was very tough. The recovery time was very tough.
Was that surgery here or at Children's Mercy?
It was actually at Children's Mercy.
Okay. And is there a reason, doctors, that they would do, I know you can't speak to this part specifically because you weren't there, but why would it be open heart when he's 18 and then cath lab when he's 29? Dr. Surface?
Yeah, there's a lot of complicated stuff that goes into that decision, and actually Dr. Zorn and I often, when we see a new patient for a pulmonary valve replacement, we do consider both options, and sometimes both are great options and we offer both to the patient, and sometimes it's patient preference. But in 2014, that was pretty early in the days of transcatheter pulmonary valve replacement. We were doing it, but not much, and so probably there were not good transcatheter options for Keith in 2014.
To Dr. Zorn's point, you had said it, technology and science moves so fast that even as recently as 2014, this wasn't.
Well, the other part is that he had his original operation as a small child, and so that's the challenge, is reconstructing when they're an infant. We'll call them 5 kilos at that time. And then how do you get them from that with a surgical operation to something that grows with them all the way through adult life now that they're a full-grown adult? So many times, even though we have the technology to put a valve in there, the conditions or the landing spot within the heart is not appropriate. So then we have to surgically, through open chest, go back in and set it up, because as we talked about, we're dealing with tissue valves. We know they've got a finite lifespan, and we've got a guy who just turned 30, and we're trying to make a plan that's going to get him to the end of a long natural life. And so there may even be more open surgery in the future that we need to consider. But we're also benefited from the fact that there's been incredible investment in this industry and from industry in this area, and so technology has turned over pretty quickly here.
Keith, you also have a defibrillator.
Yes.
Correct. When did you get your defibrillator?
I want to say in 2022.
2022.
Yes.
So does the defibrillator affect how you do this procedure?
A little bit, because our catheters and wires have to pass right by the leads. So the defibrillator leads are placed right in our way. But thankfully, most of the time, that's not a major issue. You know, we have to take extra care when we're delivering and removing equipment not to disturb the defibrillator, but for the most part, we're able to get by without too much trouble.
And so in this case, you were able to just navigate right past his defibrillator. We have some great questions and comments coming in already. So if you have something that you'd like us to ask or read out loud on the program, you can send it to us right now on YouTube, Facebook, or the All Things Heart email. All the links on how you can connect with us in real time are right there on your screen. Keith, this is my favorite thing I want to share with our viewers, because last night or yesterday afternoon you sent me some great pictures. Doctors, you haven't seen these yet. Who are you with in these pictures, and when were these taken?
So this is this is my brother on the right side.
We're going through them fast. Whose wedding is this?
My brother's wedding, I'm sorry. He's just got married earlier this year. That's a couple of groomsmen.
Where was the wedding?
The wedding was in Cabo, Mexico.
Beautiful.
That's amazing.
So.
That's wonderful. And you also
And that is us just posing, just taking a few pictures.
It's a good-looking group of guys.
Yeah.
The ladies were beautiful too. Was this something that?
And then that's me and my brother.
There you
just
go.
a month ago.
And where was that?
In Punta Cana, the Dominican Republic.
For your 30th?
Yes, for my 30th.
That's a good birthday. That's a good birthday. Were these things, when you look at those pictures, things that as the years have passed you were worried you might not be able to do?
I wasn't worried that I might not be able to do them, but I think that more so when I found out that things was going on with my heart, I was a little concerned about if I was going to make it to them, if I'm going to be recovering well, or am I still going to be in recovery time? So that was my biggest concern.
It's a lot to go through. I was just thinking about how you said you had open heart surgery at 18?
2 and 18, yes.
So you're a senior in high school. You're having open heart surgery. How does that impact just living your life as a senior in high school?
It made me want to live life a little bit.
Yeah.
I was a little nervous. I was very nervous right after high school.
Did you miss any milestones like graduation or prom or anything like that?
I didn't get a chance to just run off to college. That's the only thing. But I got to go to prom. I got to go all the activities at school and stuff.
And you're studying something now. What are you studying?
Graphic designing.
Yeah.
Yes.
Pretty cool. You're smart. Awesome. You said you like computers. That's how I know you're smart. And much younger than me. Dr. Zorn, we talk a lot about the positives of minimally invasive procedures. Mm-hmm. Why do you think it's taken other hospitals and other places longer to catch up?
Well, there's a critical mass that you need, a volume of patients and procedures to develop the techniques. You also have to have a really good relationship both between cardiology and cardiac surgery in our field. There's other fields that resemble that as well, but especially in ours where you go from the diagnosis to the decision, and that's something that we'll continue to do with Keith for the rest of his life, is kind of work together because there's some hard decisions to be made coming up, as we figure out how to manage his valves through the rest of his life.
No one's working on an island in the health system. Right. You're all collaborating, right. Which we can see through the videos we've been showing. Now, Dr. Surface, you're the director of the Adult Congenital Heart Disease Clinic, where Keith is a patient now. Can you talk a little bit about the way you're able to guide patients like Keith in their transition from Children's Mercy to adult care?
Yeah, and that's a big topic. The field of adult congenital heart disease is a relatively new one. It used to be thought of that it was just these are all pediatric problems, but what we've realized is actually most people, like Keith, with congenital heart disease are going to spend a lot more of their life as adults than they are as children. And in fact, there's probably 3 times as many adults with congenital heart disease living in the United States as there are children. And adults have different issues, and they have different needs, and they have different medical problems than children do. And so it's really very important as we help patients navigate that transition out of a pediatric care environment into an adult care environment, but make sure that they know that they're going to be cared for by people who understand their disease and who have expertise in their particular conditions. So we've developed a careful transition program from Children's Mercy to KU, and this came after your time, so you probably did not experience this wonderful transition program, but we now have a program where Children's Mercy patients are actually coached from the time they're 12, 14, 15 years old on preparing for transition. And then there's sort of a formal handoff period where actually we have a telehealth visit with Children's Mercy folks, KU folks, the patient and family, and go through everything with a fine-tooth comb and a lot of detail. And then we on the KU side welcome them into the KU umbrella and make sure that they're scheduled for all the appropriate follow-ups and referrals and things like that.
Which is so great that the health system does. It's almost like a baton handoff.
That's right.
The health system with the Children's Mercy.
Yeah.
Keith, you had talked about this, just the stress of, one, it's stressful becoming an adult, and you're on your own. No one's keeping track of us as much as they were, but also having to take charge of all your medical care.
Right.
What was that like for you? Because you didn't have all these great things that we have developed here at the health system.
Right,
now.
right. First thing is learning doctors' names and keeping up with them. You see, I have to deal with 2 different doctors now, so I have to keep up with which doctor is who to go to, who to talk to about certain things, or even just medicine-wise. So it was pretty cool.
Do you have a family member that calls you and kind of gets on your case?
My mom.
Oh, good. That's a good mom. That's
my
a good
mom, the person who's been there with me, yeah, my mom, she gets on me a lot.
She'll be doing that forever.
Right.
It doesn't matter how old you are, and that's what moms do. We have some great questions coming in from our viewers, so I want to kick things off with Denise. Denise asks, I always hear that minimally invasive is safer, but how is it safer? Who wants to take that one?
Yeah, I'll go with that one. So it is less invasive in that we're not going through as much tissue, so there's less wound to heal, and it's a quicker recovery time. It's not always safer. It depends on the anatomy, and it depends on the substrate that we're dealing with. So that's where the decision-making beforehand comes in, because you have to look at the anatomy. Trying to do a minimally invasive procedure on anatomy that's not appropriate is actually more dangerous than doing open procedures, and that's where we make the decision sometimes.
And was it you two collaborating and saying, all right, how are we going to help Keith?
Yep.
And you decided on this?
Yep.
John has a really good question. John wants to know, what exactly is a cath lab?
Oh, here you
And
go.
I remember being confused about this when I first started working here. Cath, why do you call it a cath lab, and what is it?
So a catheter, which is what cath lab stands for,
It's
is
what went
just,
up Keith's leg.
That's right. A
Okay.
catheter is just a hollow plastic tube. It turns out that those hollow plastic tubes can be very varied and very sophisticated, and that's what we use to get from either a vein or an artery in the groin or the wrist or the neck to various places in the heart. So we can take those catheters and start in the wrist and deliver them all the way up an artery or a vein to the heart, and then we can use those catheters and wires and balloons and other tools to treat problems. And the cath lab is the place where all that happens, and you need a lot of sophisticated equipment in order to make that happen. You need big x-ray equipment and those big screens that you saw. You need a sterile environment where complex procedures can occur, and you need a huge team of people. And we are fortunate to have a really advanced cath lab, including what we call hybrid ORs, which are a couple of different rooms that can either work as a cardiac operating room or as a cath lab or a little bit of both. And those are where we tend to do procedures like these transcatheter valve procedures.
All right, so when you hear cath lab, John, it's, and me, because I didn't know this, when you hear cath lab, it's a catheter going in somewhere and going to the heart. It's where all the magic happens,
That's
where you
right.
help people like Keith. Becca wants to know, Dr. Zorn, I'll ask you this one, do you think you'll ever reach a point where valves don't have to be replaced every 10 years or so?
I don't think I would never say never. We don't have that within the next 10 to 15 years that I see. I still think that there's going to have to be need for ongoing surveillance. We do have bioprosthetic valve, we do have mechanical valves that are made of a carbon polymer that are durable, that those leaflets will never wear out. It doesn't mean they will never need surgery again, because they can get infected or have clots or other things can happen around them to cause them to need to be replaced. But they're the best chance for having a forever valve, so to speak. But I don't think we're there within the next 10 years. But it's hard to predict where technology will take us.
It goes so fast.
Yeah.
Technology
Yeah.
moves at a warp speed. Jeremy Yenser, one of our Facebook viewers, wants to know, since the heart is involved in so much of how the body works, is there anything else to watch out for when you have the valve issue? So, yeah, who wants to take that
Yeah,
one?
so the short answer is absolutely yes. So when we, for example, get an echo, we're not just looking at the valve. We are looking at the valve, but we're also looking at what are the downstream effects that the problem in the valve is causing. So the pulmonary valve is the valve between the right side of the heart and the lungs. And so the right side of the heart has to pump across that pulmonary valve. And what we saw in Keith's case was that the valve was very narrowed and very leaky, and also the right side of the heart, its function was getting weaker. And when we see that, we know that it's struggling to deal with that extra narrowing in the valve.
Right.
And so that's a sign for us that it's time to move forward with a valve replacement so that we don't allow that right side of the heart to get worse.
Jean has a question. Jean wants to know, how are the replacement valves attached to the existing tissue? That's a great question.
So in this case, the valve, the one we used, has a frame. It has a metal frame on the outside, and the leaflet tissue is on the inside. And we deployed this inside the valve that was sewed into his heart before, and we're able to push the old leaflets out of the way with the cage, and then it just opens up and there's a new valve on the inside. So it is. This one is actually secured in the valve that was sewed in when he was 18 years old.
So it's just held there by the tension of the other valve.
Yep.
That's interesting. We've got a question from, let's go with Jacob, because Jacob has a question for Keith. When you were a kid, did you understand what was happening with your heart, and at what point did you understand?
As a kid, no. I just knew I had a heart problem. They explained it to me. It was a hole in my valve. They put a patch there. When I turned 18, they wanted to replace the valve just because as an adult, just to have an adult valve. But now, as I transition that into an adult, I'm learning that more things about my condition, more things that I didn't know. Like I had like 3 to 4 different holes in my heart. I didn't know that. So I'm still learning different things, honestly, every year.
You're becoming an expert
Right.
in cardiac care. Do you ever
Right.
consider a career in medicine? Because patients are often awesome caregivers.
I thought about it. I
Yeah.
took into consideration of it.
You just got to decide if you want to come to the hospital more often or less.
I'm trying to stay away from the hospitals, honestly.
I get that.
Understandable.
For today's takeaways from our guests, I would love to know what you all want our viewers to take away from this conversation. Keith, what do you want people watching to know who might be going through their own health journey?
That it is a tough road and it is frustrating, but that when you have 2 great doctors like I do and a great team behind you, that anything is possible and life can still progress and things can get better.
Jill actually has a question, and I want to weave this into today's takeaways with the doctors. So Dr. Zorn, Jill wants to know, will there ever be or have there been any advancements to help parents catch blue baby syndrome earlier? Because Keith wasn't diagnosed till he was 2.
Well, actually, that's probably a better question
All right,
for
we'll
JD.
go for you.
I'll
Okay.
give him-
Yeah.
Yeah, sure. So the answer is definitely yes. So Keith's story is not uncommon. There are a lot of patients who are diagnosed with this later on. I mean, 2 is actually still pretty good for.
It is?
Well, for an earlier era, it is. But nowadays, people have recognized the importance of catching congenital heart disease early, and there are many different screening protocols in place that are standard practice all across the country. For a new baby is born, you're going to check these, 3, 4, 5 things. And then, and usually that'll catch most significant congenital heart disease before the baby leaves the hospital. And that's really important. And in addition to that, we now sometimes, in moms who we know are at higher risk of having a baby with congenital heart disease, we will often do what we call a fetal echo, where we actually do an echocardiogram, an ultrasound of the baby's heart while it's still in utero. And so we often will be able to diagnose complex congenital heart disease before the baby's even born. And that is very helpful for some babies whose heart disease is so significant that they may not do very well in the immediate.
Right.
And we can actually make sure that that baby is born in a place where they can immediately get the care that they need. So the short answer is yes, we've got lots of techniques in place now to catch this earlier, and it's really helped a lot of people.
And as far as the message to viewers, a lot of people have someone in their family who has a heart problem or is a child with a heart problem. What's your message about the continuing care that you can get when you go to an adult clinic?
That it's there.
Yeah.
That's the main message, is that adult congenital heart disease clinics are out there. And if you do have congenital heart disease or your loved one has congenital heart disease, you need to be in an adult congenital heart disease clinic. There's just some unique issues in this patient population that are different than what we run into in more, we'll call it conventional or familiar heart disease. And so you really need an expert center to be able to take care of you. And then my last piece of the message, I'm sorry I keep talking.
No, don't apologize.
We want you to not just get care, but also thrive, like you said. We want you to have a wonderful, full, awesome adult life and not have to worry about the hospital all the time.
Well, he's doing it.
Yeah,
he went to
exactly.
Cabo, he went to Punta Cana, he's studying his graphic design.
That's right.
He's got the photos and the t-shirts to prove it.
He's got it. Dr. Zorn, what do you want our viewers to know about just the collaboration that you do?
Yeah, so I do think that the field of adult congenital is growing. He's on that wave of patients that survived their operations as a child that we didn't have. So we don't have 30, 40 years of data to look forward with Keith and say this is how it's going to go. We've got new techniques, we've got new technologies, and we're all kind of learning with this. And that's why it does take a team. You need to go to a place that has multiple options and multiple caregivers to be able to collaborate on it.
What a great team.
Yeah.
Keith, thank you for coming on the program and sharing your journey. When's your next trip? I feel like you're a man of travels.
Maybe next month.
Nice. Where?
To New Orleans, actually, for
Oh, boy.
Thanksgiving.
Oh, that's right.
Oh boy, look out.
Yep.
There you go.
Yep.
I know. I'll meet you there. I have family in New Orleans.
Oh,
We'll hit up
I'll
Bourbon
see.
Street.
Okay.
No pictures. No pictures for Mom.
Okay.
All right.
Okay.
Thank you so much. And thank you, doctors. I know you're both very busy with patients. We appreciate you taking the time to come on the program. And thank you to our viewers for being with us this morning. If you'd like to watch or share any one of our past episodes, just scan the QR code that's on your screen right now. It will take you to links of all of our previous episodes. Thanks for watching. We'll see you back here tomorrow morning.
Coming up tomorrow on the Morning Medical Update. It started with a routine checkup, then she heard the word cancer. I'm Jessica Lovell on the next Morning Medical Update. We follow one woman's journey who was diagnosed with breast cancer, then melanoma. Friday at 8.